Bonjour à toutes et à tous.
Hello, we are happy to see you here to co-moderate with Brigitte the Gilead Symposium for ATHS 2023. The whole team is offering two innovative experiences at different scales for the screening and of viral hepatitis for vulnerable patients. My co-moderator is Brigitte. She is manager of the CSAPA carried here locally. So thank you for welcoming us to your region. Good morning. Thank you, Frédéric. So we are co-moderating with Frédéric this Gilead Symposium on viral hepatitis. Let's innovate to take care for patients in vulnerable situations. This is a real challenge. I'm not really from here. I'm from Bordeaux, and I'm not the only local specialist here because Juliette is here with us. Thank you. I would like to thank Gilead and all the organizers of ATHS for enabling us to attend this symposium. So we have three guests, Dr. Alice DESCHENAU, Juliette Foucher, and Hakim BOUCHKIRA. We will start with Alice DESCHENAU, who is a psychiatrist. She's the director of a CSAPA, a care center and other structures probably in Villejuif. Alice, you have the floor. Thank you. I'm very happy to be here. I will talk to you about what we did at the Liberties CSAPA. Okay, these are my relationship with the industry. We're going to talk about what we did locally, explain 2 or 3 points. The CSAPA Liberty is a hospital CSAPA in a public health hospital at Paul Guéroult in the southern area of Paris. It's multi-site. It has a long history in the care of drug addicts, and we started methadone 30 years ago. And we are generalists now, but we work a lot with the users. We were ahead of we were leaders in terms of viral hepatitis until 2019. We worked with a pharmacy, with laboratories, with different devices, especially Gaia. And we were not doing much for 12 or 1,400 users in terms of screening and treatment. So we said we have to do something, and it was not us. For years, we wanted funds from the health authorities for screening or to have a fibroscan, and we had nothing. So since we knew what we knew about our projects, one, how to have a simplified pathway within CSAPA, I told them that I was worried because we wanted to have the eradication of hepatitis C in 2040. So for me, we were doing nothing in terms of diagnosis and screening. So I got angry, and I was surprised because I had new funds, and I was able to buy dried blood spots. We don't have much mobile activity. We work within our sites with nurses, doctors, and we knew we were with positive patients, so we wanted to go to diagnosis and cover hepatitis B and C and HIV, even if it was more expensive. So we decided to go that way. We did that in partnership with the Paul Bruce Hepatology Center and with Professor Anne-Marie Roch, who worked with us along the years to help us in improving our skills in terms of diagnosis and screening and in the care. Of course, we were also doing screening prescriptions, but clearly we really increased. We didn't do much follow-up. We know how many dried blood spots we use, but we don't have the care cascade. So that was in 2019. We have the funds and we start. And the project was to work on the simplified pathway together with a hepatologist, because we don't have that expertise within the CSAPA. So we worked with our Paul Bruce hospital colleagues, and with the support of Gilead, we created a module in with an application. I will show you some screenshots. And we first defined the content of this application for a user, for a CSAPA user, for hepatitis C. We had virology and territory CSAPAs that could register their users. So we had to define the content. We have an application, a safe application. It's a label. It has a safe data with a safe servers, like in all health institutions, and it's a shared messaging application. So the patient form with all the items to be filled in, you need the consent of the person to be registered on the platform. And the data is shared with a hepatologist and the virologist. So we need the person's consent, and then we can create the persons who are going to work to support, to counsel that person, information and viremia, risk-taking, current treatment, pathologies, comorbidity, fibrosis, liver, ecography, etc., and the final decision. Then we can go to start the pathway. We can select the therapeutic option and edit the prescriptions. There is an automatic edition of documents. As a doctor, I have I have forms for fibrosis, for ecography, for all prescriptions. So I just need to press a button and print. To show you an example for treatment, we're going to write the medication, a focus on self-medication for food complements. Then we can check the other treatments. Are there any interactions? And this is to locate all the items that would take us to a specialized pathway. Another example for fibrosis, the fibroscan, fibrotest, and each time we have the figures to know whether we are in the simplified or specialized pathway. The final decision, you see it here, the doctor. I can see the date of my decision, and I can also say, I don't have all the criteria, but I want to go to the simplified pathway, and I can say why I take that decision and have a memo at the end. The pathway, as I said, there you have both options. Then you select that with the user. We select that together, and I edit the prescription. And we have in this application a reminder system on the key dates, the viral response after 12 weeks or 1 year. So we have pop-ups and notifications. We have messages for such patient. I have to think about doing to have a new viremia to make sure he's still negative. we launched this use of the application, so the nurses are working with it, the doctors. And so we had that. We also had bloods, and the fibroscans was something where we had asked the IRS several times, but by indicating this work we did with CSAPA, we are in the same pole as somatic medicine, which is involved in the screening in psychiatric treatment. And we talked with them about what we did. So in terms of budgets for the hospital, for the equipment of the care units, we had money after the COVID, and I didn't even ask for money. They said they offered to buy that fibroscan, so it was a nice surprise for us. So since 2022, we have the fibroscan with us. It's mobile, and we can use it on the different sites. And we are a very happy team with our fibroscan. As conclusion, we don't want to be a model because we started very late, but the message is it's never too late to do things, so don't hesitate and go ahead, even for psychiatrists, because I'm a psychiatrist, so we can have a simplified pathway, even if you're a psychiatrist by training. I think these examples show that we should communicate on what we do, because we feel lonely, but then at one point we have access to something. So we should look for partnerships, for support, see what is being done elsewhere. I think these are the best way to see what can help us to move forward, to be more efficient in terms of care. One word, of course, risk reduction is still essential, and this is essential with all the work when you care people to prevent infections and reinfections. And to conclude, we should put energy in all that, because it's a pleasure to give the results of the viral response to the patients. Very often it's positive, and it's nice to enjoy to see when we see our users smile. Thank you. Thank you. Thank you, Alice. We'll have the roundtable after the interventions.
Infirmier innovant en santé. Il va nous expliquer.
And now I have the pleasure to introduce Hakim BOUCHKIRA, who is a nurse, and he's going to tell us about the precarious situation of populations. So hello everybody. I'm very pleased to be here. Thank you very much for giving me the floor, and thank you very much for letting me introduce the team. I do have a slide. Next, can we have the next slide, please? Thank you. So I would like to say that I belong to the hospital in Perpignan, and I'm in the hepatitis team, and we are working at the service of gastro and hepatitis. We have a multidisciplinary team. We have nurses, secretary, a health mediator. We have the hepatologist. So this is the responsible doctor, André Jean-Rémy, for strategic actions. And well, they're actually well, responsible for all the actions that we're doing. So I wanted to acknowledge their work. And so these are my disclosures. And this slide shows very well the mobile hepatitis team. It was created in 2013. And we're talking about a population of 850,000 inhabitants. We're talking about the region of Aude, and we are the south of France. And We work with partners who are committed to fight against viral hepatitis. We have different associations. We have extra hospital services, the CSAPA, the CARUD, and we have all different structures, specialized structures as well in hospitals, psychiatric wards, and all of this so that we can target as many people as possible amongst those who are at the highest risk of suffering from a viral hepatitis. So we have been trying to mainstream the care. We have been trying for the last 12 years to provide safety and quality when it comes to care for our patients. So in the last 10 years, we have developed different tools like FibroScan with a protocol for national cooperation between pathologists and nurses. We have the viral charge in 58 minutes with the CEFED. We have a partnership with the biologists who are in charge of validating all tests. We have also these thoughts. We have the possibility to lend telephones to our patients, and we also have these mobile units so we can travel in the region to screen patients. So actually, we're talking about 1,000 patients who have been healed and 91% of a healing rate. So these are the innovative experience. Now we're going towards, I wanted to tell you about many different things. I wanted to tell you about how we can reach most remote populations by traveling every 15 days. We can also reach seasonal staff at the ski resorts. We also have in-house visits, and we also partner with an association who's supporting women from the Gypsy community in the district of Saint-Jacques. And on top of this, we're providing support for screening and for, well, support messages. So we have very interesting figures about our capacity to screen amongst women. We also have an interactive digital workshop, and this takes place actually in associations, and this actually triggers the need amongst users for the willingness to be screened. We also developed a local protocol with cooperation. So this is the possibility for nurses in mobile units to prescribe antiretroviral treatments. So this is the title of the protocol. This is a nurse protocol for pre-therapeutic consultations that allow nurses to prescribe direct antiviral treatment and biologic tests for the follow-up of hepatitis C carriers. So, well, these patients, you know, we have to go and get them because they do not always show symptoms. And then I'm going to tell you about what we call la maraude. Now here I have the algorithm of our local protocol. So this is what patients have to undertake when they want to follow this protocol. And I have to say that actually we are making step-by-step developments, but the nurse is not there to interpret. There's always this algorithm that will tell us whether it's a yes or a no, and when we want to refer to the specialist. This is the version that we drafted. This has been the result of a joint work with the health agency, and we have therefore, well, all the protocol here. We have all the pre-requirements for the referral, for the prescription of the nurses. Nurses must have at least 3 years of experience in a specialized service for hepatitis C or viral hepatitis. Now, these are the figures. this was defined in June 2023, and there were this patients, 68% men, so 65 patients that were treated through this protocol, and 31 patients who were treated according to the AID protocol because they were meeting all the inclusion criteria. All the other patients were not complying with the inclusion criteria, or they were suffering, for example, from severe cirrhosis. There were 5 patients who could have been included in the protocol, but we could not yet implement the protocol itself. So when it comes to the implementation of the protocol, it's very easy to implement, and there's no inconvenience. And this protocol also gives value to our work as nurses, and it allows for a faster beginning of the treatment. So it simplifies the care. And the goal, this is a national protocol for 2024 that will be likely to be implemented by most teams. So, of course, once we've got this kind of protocol, we need to be proactive. We need to go towards patients. We need to try to reach patients. So I'm going to tell you about this initiative called La Maraude. And in November 2019, we started a screening initiative in a popular neighborhood where there's problems with drug use and infectious diseases, hepatitis, viral hepatitis. So this is how we started in our proactive initiative. We always wanted to work with the existing structures. We partnered with the local town council, and we started the screening project. And people had to come to us. However, one of the persons who came to us said, well, I have my dad at home and he can't move, so how do we do to get him screened? So then we decided to go to his place of residence. We decided to leave our venue, and we decided to go towards the population in that district. And well, we could screen there, and we were very welcome, actually. And we saw that there were problems with drug use. And this is how we got established there. And this is our way to move towards the people. I mean, we get out of our setting, of our venue, and then we go towards the people. And this is actually what we do 4 afternoons per week. And these are the figures, actually. These are incredible figures in spite of the important statistics that we had already. I mean, we were dealing with 20% of positive serology, and this was quite extreme, quite important. But now if we think about this initiative called La Maraude, we're talking about 49 screenings. And yes, it takes a while because these people are very far away from care. And amongst these 49 screens, we have 53% of declared drug users, and we have 60% of positive use, and we have this amount of patients who have detected RCNT. So what I wanted to conclude, I wanted to tell you that the local protocol, well, prescribing the treatment has helped, actually. The possibility of the nurse prescribing the treatment is helpful indeed. There are 3 nurses that can do so, and I hope that we will be able to do much more. And for the Maraude, this is very effective. And this is a way to go towards other people and to get out of our structure, out of our hospital. And I do invite all people to go towards patients and do this screening. Thank you very much. Thank you. Thank you, Hakim. Thank you for this for these two examples and for this involvement. And now I'm going to give the floor to Juliette Foucher. And well, we've been working together since 2006 in CSAPA and Hepatitis Center in Bordeaux. And Juliette is going to tell us about this topic, women and viral hepatitis. Thank you. Thank you for inviting me to take the floor. And this is a topic that is not very ordinary, like hepatitis and women. Is it a real topic? Well, maybe it shouldn't be, but actually there are certain specificities. There are certain things which are positive, but also others which are negative. So let's try to work on the situation. So these are my disclosures. Before talking about viral hepatitis, I'm going to give you some background. And here I'm going to be the epathologist. What is viral hepatitis? Viral hepatitis is hepatitis that is carried by a virus, and today it's much more easier to tell patients what a virus is. So viral hepatitis, we have A, B, C, D, and E. And we had found years ago hepatitis G, but hepatitis G did not concern the liver. So we have stopped at hepatitis E. We can classify them depending on their transmission. We have hepatitis A and E, which is food or orophycal transmitted. So in this case, well, we catch hepatitis, but we can heal at 100%. It's quite simple. So that's why they are not very much diagnosed, and it's pretty simple, unless for hepatitis E for pregnant women. And then there's hepatitis B and D. Why do we put them together? Because they have the same way of transmission. It's blood and sex transmission. This is sexually transmitted disease. And we cannot have delta hepatitis without having suffered from hepatitis B. And actually, with this hepatitis, that are transmitted by blood and sexual practices, we have treatments because they are chronic, but we do not reach a total healing. We can only block the virus, but if the virus is blocked, we can stop the disease, and this is good already.
Grâce aux nouveaux traitements, hein, c'est la maladie chronique dont on guérit. Ça, c'était quand même une grande
Thanks
nouveauté.
to the new treatments, hepatitis C is only transmitted by blood. There's a sexual transmission only in case of trauma. The treatment is very efficient, either 8 to 12 weeks, 3 tablets a day, 98% of healing rate. We are, of course, excessively happy that we are able to develop those molecules, because there are very few specialties where we can cure that easily and with that success rate. Now, once this has been stated, are we all equals before this type of disease? Well, we should start by stating the obvious. We are not equals in the face of diseases. Depends on our age, depends on our genetic makeup, our environment. The disease is going to be different. And so the sad answer is no, we are not equals. Are there gender-related inequalities? Yes, in general population, and also yes, in specific populations. Now, if we talk about general population, the gender difference for hepatitis is going to be more prevalent in different periods of time. And for women, for example, pregnancy is a specific period of time. There are a number of abnormalities. We know that viral hepatitis is going to decrease fertility. We know that there's a risk of transmission from the mother to the unborn child. And transmission is always at time of delivery. There's no transmission in utero. This transmission is going to be very low for hepatitis C, only 5%, which means on the flip outside, but 95% of them are not going to transmit the virus to their unborn child. So we should reassure those women. But same does not apply to hepatitis B. A mother carrying the hepatitis B virus has 80% of probability to transmit that. Now, what's very good is that in France, there's a compulsory screening for hepatitis B during the first quarter of pregnancy. So we screen for a number of viruses and we have an option. So in the very first hours in the delivery room, the baby is going to receive what we call a sero vaccination. So protective antibodies are going to protect them initially, but also first injections of vaccine. So the risk of transmission when the protocol is properly implemented is virtually reduced to zero. And the specificity to hepatitis E, not serious except for pregnant women. And the health authorities in France has raised the alarm for hepatitis E, similar to listeria. So pregnant women should avoid eat not properly cooked meat or game, because the risks are serious: growth delay and risk of fetus death. Now, the long and short of this, we should talk about hepatitis as early as possible and to women, and so not wait for women to come once they are pregnant. We should discuss when they ask, for example, for contraception. Contraception should be efficient, especially when the person is under treatment. Those molecules are going to be administered for 8 to 12 weeks, so maybe it's a good idea to avoid being pregnant. And again, it's only delaying pregnancy by 8 to 12 weeks, so that's not too long a period. We should also reassure those women, if they are pregnant and they have a C hepatitis or B hepatitis, well, of course, there's a risk. It's a low risk for C hepatitis, but with B hepatitis, as I said before, with a properly managed protocol, there's no or hardly any risk of transmission. Also, the question on hepatitis C is the option that we have to cure that disease. And of course, if the woman wants to be pregnant, so it's probably a better idea to first cure hepatitis C before they become pregnant in the first place. And we have a drug which makes it possible to be pregnant, but also to breastfeed. And breastfeed, of course, potential to breastfeed is very important for less privileged or precarious populations. So, which segues very nicely to the next point, which is people in precarious situations. If we have a look at the makeup of this population, 53% of precarious population in France are women. They benefit from social benefits, minimum social benefits, RSA as it's called here. 85% of single parent families are single families with mothers being the only parent, etc. So does it have an impact on health? Well, of course. The consequences are large, and there are many types of consequences. Chronically, there's a lack of financial means. If you do not have financial means, if you do not have money, it's hard for you to be treated and have access to health. So it's a handicap in matters of health. Those women often work in precarious conditions. They work 3 hours in the morning, maybe 3 hours in the late afternoon. And because of this schedule, which is highly variable, it's very difficult for them to also make an appointment with a GP, for example. And also they take care of the children, they take care of the household, they clean, they iron, and the health comes after all this: the children, the spouse, the household. And they do not even realize that they do not take care of the health properly. And so they do not have time, and they do not have the mental availability to take care of that. So those are, of course, pretty obvious statements, but we know that when you're less well off, you're also more exposed to professional violence, to violence from your spouse. Also, this month you may have seen signs and posters. This is Pink October. So this is a month where we try to raise awareness on breast cancer. And of course, those women less privileged background do not have a proper breast cancer follow-up. And also, when you are a woman, you're also more exposed to the risks of becoming a sex worker. So yes, there's an increase of prevalence of B and C hepatitis and less good access to care. Now, women and usage of drugs, drug usage. Are they the same, drug users, whether they are male or female? Well, no. When you go in those structures, you see that the profiles are different. The population of female drug users is very precarious. They have usually a very difficult history. They usually use many drugs, often, as I said, background very unprivileged, more exposure to violence, more social vulnerability. So those are factors that just add up. Also, they are, of course, even more exposed to viral risks. There's a risk of sex transmission, for example, hepatitis B, because often sex is not protected, but also women are less autonomous and they are with male partners, and so they share the paraphernalia more, they share their syringes when a partner is present, friend or whatever you want to call them. So the risk of hepatitis transmission is a lot higher in those women. And also, when you're a woman using drugs, there's major stigma, a lot more stigma than in male. As if, because you are a woman, it should, prevent you from using drugs. You're a woman, you should not use drugs in the first place. And it should not happen if you're a mother. Being a mother plus a drug user, that's top horror for general population. But those things happen. And unfortunately, this is a vicious circle, which is even worse and even more difficult to break for those women. And again, of course, I identify very much with you working in addictology. And I have to say that our structures and the response that we provide is not adapted to women. And there's still room for a lot of improvement. Sex workers are, of course, even more vulnerable and precarious. There are many, sex without protection is required by a number of male patients. Sex is associated trauma and increased risk of transmission. And then the special population of migrant women, different situations. Either they come with a family, so their spouse and their children, and so they are going to be managed differently. So those women, they never come into consultation by themselves. Either the father, a father figure, a brother, a husband is present, and they are often the one who translate. Are the question properly asked, and do they dare answering? The answer is no. And then there's another share, another subtype of population. Those migrant women, they come from Africa by themselves. It's a little number, low number of women. Also, maybe many leave, but very few arrive, if I may say. And so you have many of them suffering from PTSD. Anyway, all those women have had they have a history. Some of them have gone through delivery, C-section, a number of trauma, And we know that the prevalence of C hepatitis is a lot higher in women compared with men. So they are double more susceptible to carrying hepatitis C. So we need to remove the obstacles or the hurdles. We need to improve the way we take care of those women. We also, that should go through the peers. So what we do for male, we should do for females as well. Create a connection to users, and it applies all the more to women because women will feel more comfortable talking or being in contact with a female peer worker. So we are very fortunate to have a peer worker in Bordeaux, but it's not easy to recruit peers, female peers. We should also try and organize meetings, consultations that are dedicated to women. Drug users, sex workers. It can be one-to-one meetings or community-based meeting, but it should be a safe space, a safe moment when they can talk and feel protected. Of course, we need to have solution for mothers and their child. And it's true that if we have solution where we require the woman to leave their child, of course, we're going to say no. And also we should foster language learning. When you have a translator, you do not know what's translated if a translator is not a professional translator. Of course, this is a statement by the interpreter. Women are more gifted in languages than male. And so in a group, quite often, when you have a group of migrants, women are better at learning a language and they become the resource person in translation. When all's been said and done, well, gender equality is not quite there. We need to continue and raise awareness. We should do positive discrimination. So yes, we need to empower women in order to reach that balance between male and female, because we're not quite there. And one day, I think that's pretty great, because the International Women's Day will be every day, and I will no longer come here to make a presentation on women and hepatitis. And so I'm looking very much forward to that day. Thank you very much, Juliette. You said that you didn't have much to say, and actually you had many things to say. Now we're going to hand it over to the public to see if they have questions. There's one at the very back. I see a raised hand. Hello. I'm a doctor specialized in addictions in Lyon. The question of screening is of interest to me. And the experience that you have in CSAPA, this is a question for Alice. The implementation, I think it's a very good idea. And I wanted to do who's in charge of implementation. So is it a free of charge program? And so when the patient is not in the simplified pathway, do you have other pathways? Do you have notifications, for example? If you have someone coming in for a GI tract consultation, do you have notifications? Well, thank you. Yes, we have this app, and there's a module in the app. It's amongst other tools, and of course we could use that module. Of course, it's not free of charge. It's a company. The name of the company it's PandaLab, but of course you can go and talk to them, PandaLab, and ask them how much it would cost. So you know that there's a reference center, the viral load department, the liver department. So maybe you can ask for a quote and see, yes, if you could use that app for the GI tract consultation. And then, well, depending on the budget, you need to find funding. But the module exists, so the answer is yes. Now, on notifications, those are notifications that are sent so that we can check the viral load. Now, this is for direct communication. And of course, we can write directly to the hepatologist. We can either send a note directly in the patient's file, or we can send a more general message. So I hope I'm answering your question. I have a complementary question. There's something on which we're very, very bad. Well, of course, we screen, we cure, that's easy, but retesting. For those users that continue and digress, do you have retests? Because, well, the notification is sending a message to the user after they are cured on a yearly basis. They receive a message asking them to come back to be tested. It is usually every year. Sometimes it's more frequent if it's an at-risk population, but yes, there's a notification to ask them to come back. Thank you. Are there other questions from the public? It's a question for Juliette. I have the impression that tattoo, we talked very much about tattoo being a transmission vector in migrant women. Are you under the impression that tattooing do you think there's a gender related to tattoos and the rest? Well, I was very surprised because figures were just published on French population. Apparently, we have 50% of the overall population with a tattoo. So I was surprised, and so we need to screen. So you should screen half of the population after they've had a tattoo. Well, it's going to be difficult. I don't think that's a gender-based approach to tattoos. In precarious populations, you know, there are so many risk factors, so many confounding factors. It's difficult to pinpoint in those specific subset of population what is, you know, there's not only one factor. There are many vulnerabilities. The history, the use of substances, and also tattoo, to make matter worse. So I'm not sure that tattoo is a factor. It's one among others. Well, it's difficult, you know, during the World Day. It's difficult to go on a beach and say, oh, I see you have a tattoo. Are you aware that there's a transmission risk? It's difficult, you know, people are shouting at you. I know screening is difficult in that population. For a while, we had a number of awareness raising campaigns in younger teenagers in high school and in secondary school. And I went in those schools and explained, well, this is when you can have a safe tattoo. And I was just, you know, focusing on the safety of where you should get a tattoo and where you should not get a tattoo. A comment, just in Perpignan, where I come from, there's a fair, an exhibition. This is the national exhibition of tattoo and tattoo professionals. And we had an action there before COVID where we would have a stand, a booth, and we would raise awareness on safety of tattooing. But also tattoo professionals are not against our action, because tattoo professionals that use good material, good equipment, and sterile paraphernalia or material, they are more than ready to support us. And tattoo professionals should have a certification by the High Health Authority. I think it's compulsory since 2019, if I'm not mistaken. So, of course, there are still, you know, some that are just not complying with that. I have a question for the hepatologists. When I have an hepatologist saying, well, I do not want to start an antiviral treatment in a patient misusing alcohol, well, maybe change hepatologist. if it's impossible for you to have a different hepatologist, you can start the treatment yourself. You know, is your part, because, well, if the patient is in this simplified pathway, you know that you are entitled, you have a right to prescribe the hepatitis C treatment. Of course, you have to be honest, 1 pill a day or 3 pills a day during 8 weeks, it's not difficult. You have many tools at your disposal. So jump right in, and maybe you do not need the hepatologists. Well, I hope that there are less and less hepatologists who refuse hepatitis C treatment in alcohol users. I know that alcohol is one of the criteria. I know that we are faced with this situation. And of course, there are many liver specialists that are against hepatitis C treatment when there's still an active use of alcohol. So if we are not able to assess fibrosis, of course, it may be difficult, but if we have a good assessment of fibrosis, plus a patient willing to be treated, well, the alcohol factor is not necessarily something that we should fear. And it's true that in this pathway, we know that we have a number of criteria, and one of the criteria or the criterions is that there's no alcohol active consumption, but in practice we treat those patients. Question at the back. Hello. I'm sorry, I have a sore throat. I come from Brussels and I wanted to share our experience, which is very different from yours. What I'm hearing here is that you have a simplified pathway, you standardize prescription through nurses. In our case, patients, they have to go to a hospital, they have to see a liver specialist so that they receive the hepatitis C treatment. So our situation is very different from yours. It's a major obstacle to treatment access, in particular outside of Brussels, because in Brussels we are very fortunate where we have a team, we have a setup, we have an outreach team, and they go and raise awareness, they have the screening material with them. So that's very good for Brussels. And also we have a mobile unit, so we are reaching out and we're trying to transition those persons so that they go in the hospital. And we also have consultation times that are very extensive, because we know that the question of access to care as quickly as possible, of course, is of the essence. However, outside of Brussels, such mobile units are very scarce, and we lose many patients between screening and treatment. Now, what I wanted to tell you is that there's an advantage. There's an advantage in referring the individual to the hospital, because we realize that when the person goes to the hospital to receive treatment, there are also positive, it's a positive experience for them. So it's a positive experience for them with the hospital, because they may have had negative experiences before. And so the fact that they have to go to the hospital is potentially positive, because then potentially they are going to use the hospital for other health concerns. It's a positive experience. They see that they can access care, and the hospital can be, it's not necessarily a place of violence, etc. So it's a major obstacle that they have to go to the hospital. However, there are plus sides as well. Well, it is very unfortunate that there is a hurdle to access to care. However, I concur with what you say. In our experience, patients that reach us, they realize that the hospital is not a terrible place. And of course, it's a question of priorities. Of course, you need to have dedicated consultations. We need to have extended opening hours or opening times. But we realize that those who go through that pathway, then they stay. They are very compliant. So for B hepatitis, we need to have a very close-knit follow-up. And so when we ask them to come back 1 year later, we have more than 80% of them showing up for that follow-up visit. So I agree with you. It's a good way for them to realize that the hospital can be a safe place. Yes, and also we see that those individuals then think, well, maybe it's a good idea maybe to have my teeth checked or to have my heart checked. And they realize that the hospital is the right place to go and have that checked as well. And it's also a victory, I would say. Are there other questions before we wrap up? It's a question for Hakim before we conclude. So you're a nurse with an advanced practice. What can you tell us about this? Well, I had this project. I wanted to be a nurse, but then I realized that after a master in as a nurse in liver practice, you realize that as a nurse, it's not possible for you to prescribe treatment. So it's just thanks to the protocol that I was able to access a particular training. And so, it's not your regular nurse who's going to be able to become a treatment prescriber, but yeah, there are ways. So do follow your dreams, It's possible to innovate. We all make progress at our own speed, but from all the experiments that were presented today, we all have ideas. Sometimes there are obstacles, but we need to cross those, overcome those obstacles. All of you, you presented local initiatives, and sometimes you have local protocols and local experiences and experiments with the local health agency. We all are a reservoir of change, and I think we should be bold and dare. And I would just like to add, for many years for hepatitis, we've had all the possible tools. We've seen the TRODS, FibroScan, GenExpert, blotting paper, so many tools. And Alice, Hakim, and Juliette, they are very motivated. They have different projects through which they reach out and they try to adapt. And I think we have a major challenge that we need to take up. So we have many tools, we have access to this, but in the specific current context, our populations are complex, and the theme of the symposium was precariousness. I think that precariousness is going to increase, extreme precariousness, more and more precarious persons we deal with, and this is a very particular setup. We have a high turnover in our employees. It's difficult to continuously train our resources. It's difficult to train. We want to maintain a high quality in the health pathway, so it's a challenge, and so we should certainly brace ourselves for that, because hepatitis should not become the second important matter in CSAPAs. It's still key. Any other questions? Well, if there are no further questions, we're going to wrap up and we're going to have lunch. Thank you very much, and thank you to Gilead for this symposium. Thank you to all the speakers. Thank you very much.